So this morning, we're very fortunate to be hearing from Dr. Paula Busse. Dr. Busse earned her medical degree from the University of Rochester, followed by residency training in internal medicine and then fellowship in clinical immunology here at Mount Sinai. Now, as a member of the faculty, Dr. Busse currently serves as an associate professor within the Division of Clinical Immunology. As a researcher, she has conducted over 20 clinical research trials on angioedema, asthma, and urticaria, and is the first author of recent U.S. guidelines for the treatment of hereditary angioedema. She's an elected member of the Medical Advisory Board for the U.S. Hereditary Angioedema Association, and also an elected member of the Board of Directors of the American Academy of Asthma and Immunology. In addition to her clinical and scholarly pursuits, Dr. Busse also dedicates time to teaching the principles of immunology to new generations of medical learners at all levels. A very warm welcome this morning to Dr. Paula Busse.
Hey, thank you. Sorry, just making sure that technically I'm okay. What do I do? Where do I think it's this one. Okay. Am I all set? Can they hear me?
Yep.
Okay, can you hear me? Okay, great. So thank you. So first of all, I want to apologize for my really poor computer skills. So you'll probably notice that through the presentation. But most importantly, I'd like to thank the Department of Medicine for asking me to speak today. And the presentation is entitled Update on the Classification, Diagnosis, and Treatment of Hereditary Angioedema. Oops, how do I get this forward? Oops, I need help. Sorry. Sorry. How do I get this forward? There we go. Got it. Okay, so these are my disclosures. I've done many research studies with hereditary angioedema. Fortunately, I think I've done studies with all of the companies, so I should have no bias towards one company. So the learning objectives are today to understand the distinctions between histamine versus bradykinin-mediated angioedema. And these are large differences, and these are important differences to understand because it's going to direct treatment or potentially mistreatment. I'm going to discuss the clinical presentation of hereditary angioedema, which I'll call HAE, describe the evaluation for HAE, and describe the current and pipeline therapies of HAE. I'd like to add that in the past 10 years, there's been an amazing, we've had several new therapies, and it's really changed the landscape and the quality of life of patients with HAE. So to start out with, I think it's important to define what angioedema is, just so when we're looking at patients, and many of these features are going to help you determine, is this angioedema, and also is this angioedema from histamine or bradykinin. As some of the slides will come up, it's really important to determine the mediator because it's going to determine your treatment. So angioedema in patients with either histamine-mediated or bradykinin-mediated is non-pitting. It's usually localized. It usually may involve just one extremity. So if you see two lower extremities, again, you may not be thinking of angioedema. Results from fluid extravaganting into the deeper dermis. This is important to mention to patients because many times patients may expect that once you treat them, that the swelling will resolve quite rapidly, but it takes a while for the fluid to resolve. It tends to affect certain areas of the body: face, tongue, lips, periorbital tend to be the most common sites. The sites that are most threatening to patients are if it affects the airway. Also can affect the GI, the GU sites as well. So the etiology of angioedema, we can basically kind of loosely put it into two buckets. And as I try to explain this to patients, the most common type is mast cell mediated, and that's going to be about 90% of patients coming in without a known diagnosis of the etiology of angioedema. And this is usually caused from, mast cells releasing histamine, leukotrienes, prostaglandin. And again, an important point of this, and this is an important point of the history, is that patients are often going to have itching and hives with this group of angioedema. The next less common is the kinin related, which is the focus of my talk. And that's going to be from generation of bradykinin and complement-derived mediators that instead of having histamine cause vasodilation, bradykinin is going to cause vasodilation. Patients with bradykinin mediated don't have urticaria, and they don't have itching. And the timing, as some of the slides will come on, is relatively different than the mast cell mediated. So again, you have certain clues that are going to direct your initial thoughts. Oops. So the subtypes of kinin-mediated angioedema, again, these are very rare, but the most well-known or well-described is what I'm going to talk about is hereditary angioedema with C1 inhibitor deficiency. We have two types, type 1 and type 2. We don't necessarily, the treatments can be the same for type 1 or type 2. It's just a difference of genetic mutation. We also have a newer entity, which is called hereditary angioedema with normal C1 inhibitor. Again, we're learning about this, and this has been described in the past 10, 15 years. Again, we've described some mutations in this group of patients, and some we don't know. The more other types are acquired C1 inhibitor deficiency, which I'm not going to focus on, but with that, again, this patients many times have an underlying malignancy. I've identified several patients who have developed malignancies. They've had swelling first and then later been diagnosed with a malignancy. ACE inhibitor, not so uncommon, but this bradykinin mediated and idiopathic. Just to touch a little bit upon HA with normal C1 inhibitor, the mechanism we're still beginning to understand, but it's likely bradykinin. And as I mentioned before, in the past couple of years, we've identified several genes that may potentially be the cause: factor 12, angiopoietin, and plasminogen. And these genes can be sent through an in vitro panel. And again, however, because we're learning about this disease, most of the patients or several of the patients don't have the diagnosis or can't have the gene identified, which makes the diagnosis a little bit tricky. And I'll come up to the diagnosis in some of the upcoming slides. Histamine-mediated angioedema, I'm not going to touch upon this, but except for the fact that it's critical to make sure that when you're treating a patient with angioedema that you try to, from the history, determine if it's histamine-mediated or bradykinin-mediated. These tend to be quicker onset. Many times there's identifiable triggers such as food, drugs, or it could be non-IgE mediated, such as non-specific mast cell stimulation from opiates, radiocontrast dye, arachidonic from NSAID ulcerations, or even in some patients have an autoimmune component where patients develop antibodies against the IgE receptor on the mast cell. This table is kind of what I've been hinting about, looking at some of the features to determine between bradykinin versus mast cell mediated angioedema. The rate of onset is very different. For mast cell mediated angioedema, such as food allergy, I often explain to patients, if you're allergic to peanut and you eat peanut, usually you have symptoms within 15 minutes, really fairly rapid. Whereas bradykinin mediated angioedema, such as HAE, the onset is much slower and it often takes about 24 hours. So in this sense, it does give patients a chance to seek emergency help for bradykinin, or what I'll be coming to as well is that when they feel that their symptoms are coming on, they can treat early, which will help prevent the progression. The duration of swelling is very different. Patients with bradykinin-mediated angioedema often have swelling for 3 to 5 days. So this is an important point that I ask in the history. How long did your swelling last? Usually with mast cell mediated, it's less than 2 days. Urticaria is a distinction. We don't see that in bradykinin-mediated angioedema or itching. Pain or burning may be present with bradykinin-mediated angioedema. Again, another important point, which can be a little bit of a sticky point, is the clinical response to treatment. The response to antihistamines is critical. However, as I mentioned before, many times when you treat or when you give medications, it takes a while for the swelling to resolve. So patients will oftentimes, or many times, come in frustrated and say, oh, I was given, Zyrtec in the emergency room and nothing happened. Again, this is a clue, but it's not end all be all. It may be that it was given and the swelling had already presented. Coming up, or in some of our guidelines, the response to antihistamines, we've defined that as the ability to prevent swelling using high doses of antihistamines. Also, the response to corticosteroids. Bradykinin-mediated angioedema is not going to respond to corticosteroids or antihistamines. So these are clues in the history. The epidemiology of HAE. It's a rare disease. The estimated, we don't know the exact prevalence, but we guess that it's between 1 in 30,000 and 1 in 80,000. It's an autosomal dominant inheritance. However, about 25% of the time, it is a new mutation. So when we're, even though the name that is hereditary, again, that a patient doesn't have a family history of angioedema doesn't exclude it. I have several patients that have had new onset angioedema and they've had a new mutation. And it's important to counsel these patients who have new mutations that they can pass their mutations on to their offspring. There's no known ethnic or gender differences. The average, again, this is a little bit old data, and the reason why is that we have treatments now, but in the past, when we didn't have good treatments, the average attack rate was about 1 episode every 2 weeks. However, we don't have good biomarkers, or we're at this point to say, listen, your disease is going to be very severe. We need to treat it more aggressively, or your disease, you're okay. You're not going to really have any attacks. Even though family members have the same genetic mutation, we can't use the family history to predict how the disease will progress or not progress. And it's not, we can't even use the level of the C1 inhibitor function. We can loosely use it, but again, we can't use it to make predictions, which again, this is scary for patients, or it has been scary for patients with newer disease or newer therapies. Again, the landscape has really progressed. But again, also this is an important point that you have to counsel, and this will come up some of the slides, that patients, since we can't predict that they will or will not have a life-threatening airway disease. The features of HAE, again, it's angioedema without urticaria and it's severe. Patients have extreme swelling. I have some upcoming slides. The swelling tends to be in the face, airway, extremities, GI, or GU. The attacks are prolonged. They increase over about 24 hours, which often gives patients some time to treat early, and it resolves in about 2 to 5 days. Unresponsive to antihistamines, corticosteroids, or epinephrine. Again, this HAE, the attacks are unpredictable, which again, really has been understandably nerve-wracking for patients, and has caused a major impact on their quality of life. Before we had good treatments, patients didn't want to travel. They were afraid that something may happen. Stress and emotional stress is a huge trigger, as well as trauma or surgery. I'm going to walk through some of the attacks. The most common site of the attacks are extremities, such as the hands. Again, this may not seem such a big deal, but it really is. Patients can't function. They can't use a computer. They can't put their shoes on. So it really, even though it may not result in a hospitalization, it has a major impact on patients' quality of life. And again, there's been a little bit of debate in the literature, and now. So in the US, we say to treat all attacks regardless of the site. In the European countries, we're saying maybe not treating extremity attacks. But again, we encourage treatment because it causes a major impairment in quality of life. Airway attacks, these are the most feared. Before we had good treatments, it occurred in about 50% of patients. And again, I've heard stories, and they're heart-wrenching, of family members witnessing other family members dying from an airway asphyxiation. And this was before, about 15 years ago, when we didn't have treatment. Intubation of airway swelling with HAE is difficult. And again, this is the most feared complication of HAE. And again, we have to I make it very clear to patients, not to scare them, but they have to be aware that they are all at risk for an airway attack and need to have emergency medication on hand. Abdominal attacks can be quite severe, and they're quite common in patients, and they often present as like a surgical abdomen. I have a couple of patients, even though I've written notes that they have HAE, have gone to an emergency room, not Sinai emergency room, but when they've been traveling and had an abdominal attack, only to be taken to the operating room to have a normal appendix removed. So again, it's, even with a note stating this is HAE, that, this is how you treat it. It's not a common disease. And again, misdiagnosis often happens, but less so now. But again, patients can have hypotension, vomiting, the intestinal swelling could be significant enough that there could be intestinal obstruction. Oops. Okay. The clinical features of HAE with normal C1 inhibitor. Again, we are learning about this disease, and the diagnosis is somewhat difficult to make, but hopefully some of the upcoming slides will touch upon that. So this is a similar presentation as HAE type 1 and type 2. They tend to not have, as I didn't mention before, but some patients with HAE get a rash called erythema marginatum, which is kind of a serpentine type rash. This is not hives, but often patients will get this prior to having an attack, kind of as a prodrome. But patients with HAE with normal C1 inhibitor don't tend to get this. Patients in the normal C1 inhibitor tend to have more facial attacks, tend to have more disease-free intervals. It tends to be more females. There are rare male case reports, and it has to be an autosomal dominant disorder. So again, this is part of the conundrum we have in making the diagnosis. We have to make a diagnosis where we ask the history, say, did you have a family member, a first degree family member who had unexplained death from airway swelling or unexplained swelling? So again, we need to have that history, but then again, you could say, well, it's a new mutation in the one of the genes causing HAE with normal C1 inhibitor, which is difficulty in making the diagnosis. The same tends to be the same triggers for this entity. However, estrogen possibly is a greater influence. The pathophysiology of HAE. This dates back to William Osler. Again, HAE was first described as hereditary angioneurotic edema. Fortunately, this label has been removed and is just called hereditary angioedema. It was called neurotic because patients often, understandably so, had witnessed family members die, or they had unexplained swelling, and doctors, or they went doctor to doctor to doctor until recently. I've seen several patients that have gone potentially, some of the older patients have gone 35 years without a diagnosis, being told they're crazy, being told they have Crohn's disease, a weird allergy. And again, so you can understand why patients had a large psychological component. It was not until the 1960s that it was determined that the underlying etiology was a mutation in the C1 inhibitor protein. And this is important not only for making diagnosis, but approaching therapy. And I'd like you to pay close attention to the dates. This is 1962. And when I come up with some of the treatments, you'll see that there's a huge gap between the discovery of the gene and treatments. So this is the function of the C1 inhibitor in the contact pathway, as well as the complement pathway. Really, it is, even though C1 inhibitor inhibits several sites in both pathways, it really is the focus on the contact pathway. What the focus is that the yellow dots are where C1 inhibitor prevents activation of bradykinin. So bradykinin, or C1 inhibitor will help cleave kallikrein to high molecular weight cleaved kininogen, which will produce bradykinin. So bradykinin, this is the generation of the swelling. It also affects the complement pathway, but it's really not a complement disease. But the nice point is that we can use several of these markers, such as C4, in order to make a diagnosis. So C4 in patients is a good screening tool for hereditary angioedema. It's always going to be low regardless of disease activity or not. Bradykinin, we don't have good, is very difficult to measure. And as some of the upcoming slides will mention, we have several surrogate markers that we can use for bradykinin generation. So what happens here is that when bradykinin is released, it attaches to the bradykinin 2 receptor, which causes vasodilation and subsequent angioedema. This slide is busy, but I like it because I was an author on this paper, but also it was a lot of work. But again, if you look at the reference and you can go to the, it gives a overlay of how the contact complement pathway and fibrinolytic pathway overlay in HAE. And what I'd like to point here is that similar to the other slide, we have that high molecular weight kininogen with activation of kallikrein, which becomes activated from C1 inhibitor or lack of C1 inhibitor, will cleave high molecular weight kininogen and also release bradykinin. We can use high molecular weight or cleaved high molecular weight kininogen as a marker of bradykinin activation. And this has been important for several of the upcoming studies. We can also, this chart also demonstrates how angiotensin converting enzyme is also an enzyme that can degrade bradykinin. So in patients with HAE, we recommend that they do not take ACE inhibitors because it's going to interfere with degradation of bradykinin. We're also, in terms of the pathophysiology, carbonyl peptidase N and M degrade bradykinin. Estrogen interferes with these enzymes. So we feel that that is a mechanism for why estrogen can increase HAE symptoms and bradykinin expression. How do we make the diagnosis? This is a table, and it's let me walk you through it. So there are HAE type 1 and type 2. And then we have HAE with normal C1 inhibitor that are labeled as HAE mutation and HAE unknown. ACID is acquired C1 inhibitor deficiency, which is when patients often present with swelling and potentially later have an ongoing malignancy driving the consumption of C1 inhibitor. ACE inhibitor and idiopathic. So what I'd like to draw the attention here is that C4 is a critical component for making the diagnosis of HAE type 1 and type 2. And this is always going to be low, and it's a serum study. So if you see someone in the emergency room or you see someone that you're evaluating, you can always add this on later as a test if you think about it. You know, it's not something that has to be drawn at the time or processed at the time. However, the distinguishing feature is that the function of the C1 inhibitor is going to be low with HAE type 1 and type 2, whereas the HAE with normal C1 inhibitor, these levels are all going to be normal. The HAE function test is a very sticky test. It has to be processed properly, and it has to be processed as soon as it's drawn. So it's not a test that you can add on. It has to be frozen and then sent. There are two labs. If it gets sent here, it's an ELISA method. You can also send it to National Jewish. They have a different Quidel or a different method that we use. So again, there's two methods that can be used, but it has to be processed properly. I get a lot of referrals for patients with normal C4 with abnormal C1 inhibitor function who have had the processing of the C1 inhibitor function has not been done properly, and patients have been put on HAE medications. So again, as you can see here, oftentimes it's how do we distinguish between HAE with normal C1 inhibitor versus idiopathic? ACE-induced is, by history, but again, we have good tests for HAE type 1 and type 2. Unfortunately, these tests don't have a quick turnaround in the emergency room. It takes about 24 hours for C4 levels to come back. The C1 inhibitor function will take several days. So again, if someone's coming into the emergency room and they're presenting with angioedema, it's not wrong to treat if you don't know that they have HAE as if histamine mediated, and then if they don't respond, to consider another etiology. These are some of the clinical differences, as I mentioned before. The C1 inhibitor function in HAE with C1 inhibitor deficiency, type 1, type 2, is low. No difference, but it's normal in the HAE with normal C1 inhibitor, hence the name, normal C1 inhibitor. The normal C1 inhibitor tends to be more female. We see a lot of kids, it's more common. So we screen first-degree family members. We screen, the children so that we know in case many times it's interesting, parents don't want to know if their kid, if they passed on their HAE to their kids. But again, I really try to counsel them that you want to know in case they have swelling, is this HAE, how it's going to affect treatment. The swelling frequency is going to be a little bit more in HAE with type 1, type 2. Going to be more so in the extremities and the abdomen, whereas HAE with normal is going to be in the face. Their tongue swelling can happen in both, and both are at risk for asphyxiation, which is the most feared complication. The goals of treatment really have changed with the modifications and the approval of several of the medications. Our goals are to decrease morbidity and mortality and allow patients to restore normal quality of life. Again, it's amazing to hear the stories of patients, how they, I've had patients before who didn't want to have kids because they didn't want to pass on their disease, but now patients are traveling. The quality of life it's incredible how it's changed. I'm part of a group which is an amazing organization called the U.S. Hereditary Angioedema Association. It's run by patients, so they understand the disease. And many of these patients have had HAE for several years, and they've witnessed that time from having no treatment of acute attacks to now having several options. So again, they're on us with the board. And again, we've made recommendations. We made initial recommendations in 2013 and recently updated them. And again, because HAE is a rare disease, we like to make these recommendations, and really it has to be a group effort in taking care of patients. We recommend that patients are followed by an HAE expert. I have patients that are over the country, but again, I would say, follow with me once a year. So I do a lot of co-following with other physicians. As I said before, we have to screen family members. We did a study a couple of years ago, screening family members who were asymptomatic, and found several members who had had deficiency of C1 inhibitor, but had no symptoms yet. So again, these patients are at risk. We have to coordinate care when patients have surgery, when patients go delivery, again, childbirth. Again, there's a lot of coordination of care. We have to coordinate care when patients get wisdom teeth pulled, extracted. Again, we have to, tell the surgeons or the oral surgeons that you cannot give a dose of corticosteroids and the patients will be fine. You have to counsel them that they need a different prophylaxis. There's patient and family education for the schools and for the families. And again, discussing some of the options that we have and providing a detailed treatment plan. And this really also includes a way that patients can get in contact with you easily. So our guidelines have recommended that all patients must have 2 doses of an FDA-approved on-demand medication. This is in the past 10 years, the FDA has approved on-demand medication. So if you can imagine, about 10, 15 years ago, we had no treatments to treat acute attacks, how this has improved the landscape. We recommend that all treatments all attacks be treated regardless of site. Early treatment is important. Again, some patients will say, the medication is very expensive and it's incredible. It's, 1 dose of some of these medications could be $8,000. And I have a story of a patient we used to treat, teach patients how to infuse by putting in a butterfly needle in. And one patient left a month's worth of her medication on the bus. So that was about at least $24,000 worth of medications on the bus. So some patients like to not use their medications because they worry it's expensive and they're going to run out. But again, we really have to encourage that early treatment is effective, meaning that within about 4 hours of swelling. If patients have airway swelling in the airway, that we recommend treat and go to the emergency room. Patients in the past have been very frustrated going to the emergency room because they were often misdiagnosed. But again, really, since the improvement in landscape, the emergency room has become much more familiar with HAE, which has been great for patients. Besides acute treatments, we have preventative treatments. And again, this is really, you might say, well, why shouldn't all patients be on prophylactic treatment? And you'll see with some of the slides is that in the past, all we had for prophylaxis were androgens, which are, testosterone, which you can understand why a female patient may not want to take, or even a male patient with some of, several of the side effects. So again, you have to really weigh the side effects of the medication versus the efficacy. Now we have more and more patients going on prophylactic therapies because they are improving, and they're improving in terms of preventing attacks and also improvement in the modality that we're administering them. So we don't have, in our guidelines, we don't have it that you say, oh, you have one attack a month, you should be on prophylaxis. We don't want that. We want patients to decide to be on prophylaxis because we want to improve their quality of life and also decrease the frequency and severity of attacks. This is a chart that shows some of the medications we have for prophylaxis as well as acute attacks. And I'd like to draw your attention to the date of approval. As you can see here, androgens were approved in 1971. Then we have a huge gap until 2008 when we have C1 inhibitor was approved for prophylaxis. So if you can only imagine the frustration of patients between 1971 to 2008. In Europe, there was C1 inhibitor approved. So what happened is that there was patients sometimes would travel to Europe from the United States, and if they could afford it, they would buy C1 inhibitor and then bring it back to the United States. Fortunately, in 2008, C1 inhibitor was approved for prophylaxis. I'd also like to draw your point that this is an IV prophylaxis. Let me go through the next slide. The IV prophylaxis is given every 3 to 4 days. So patients, although they were thrilled to have a medication besides danazol or one of the androgens, which had enormous side effects, very not tolerable, didn't always work well, to have an IV therapy that they would administer at home every 3 to 4 days. And I often got questions, are patients compliant? Yes, actually patients were extremely compliant with putting an IV or a butterfly needle in every 3 to 4 days because they didn't like the androgens. They didn't like the fact that they were getting attacked. So the compliance was extremely high. Then we have that in 2017, a few years ago, that a sub-Q formulation has been developed. Again, this is every 3 to 4 days, which is better at sub-Q, but it's still every 3 to 4 days. And I'm going to touch upon some of these medications. Now we have a plasma kallikrein inhibitor, which is sub-Q. I'm going to touch upon another slide. Acute therapies. We have several sub-Q options as well as IV options. Again, as you see, these are sub-Q or IV, no oral options at the moment. 2009, we had the Calantide approved, which was approved. However, it has the risk of having anaphylaxis to it. So patients cannot give it to themselves. All these other medications are approved for self-administration, which is great. Patients can give it to themselves at home. But again, the theme is we have had a huge delay in approval of medications, but now we've had a surge. The medications are transitioning from androgens for prevention to IV to sub-Q. And as we'll see, some back to oral medications. These are 3 of the medications I'm going to touch upon, and we were involved in several of the studies here at Sinai. So the lanadelumab, we were involved in the phase 1B study. And again, this was the phase 1B study, was looking really at the dosing more than the efficacy. However, we met the efficacy points for patients. Patients got 2 doses, patients with HAE, and it was actually very apparent who got the active versus the placebo. And what we measured was not only the main primary endpoints was looking at the inhibition of cleaved high molecular weight kininogen, which is by several methods as a marker of bradykinin, and then efficacy was a secondary endpoint. We found that at cleaved, the high molecular weight kininogen at baseline in patients with HAE who are not having symptoms was about 51%, and healthy controls was about 8%. So this is a striking difference. When patients were treated with both the 300 and the 400 milligram doses, it suppressed the cleavage to near levels of healthy. And again, this was confirmed by several assays. So this led on to the phase 3 studies. Again, the phase 3 studies were designed looking at several different doses based upon the phase 1B, 300 every 2 weeks, 300 every 4 weeks, 150 every 4 weeks, and placebo. And patients, again, these are hard studies for patients. They have to go through a run-in phase with no medications, kind of to demonstrate their attack rate. So they have to get attacks in order to qualify. So it's incredible work that patients have gone through, that they want to help to get new medications. This medication, lanadelumab, was approved in 2018. This is at a dose of 300 milligrams initially every 2 weeks, based upon the efficacy data in decrease in attack rates. And again, the FDA has approved it so that if patients don't have attacks when they're getting the sub-Q medication, then they can switch to once a month. So we're going from patients potentially giving themselves IV medications every 3 to 4 days to a sub-Q injection once a month. We just completed studies in kids less than 12, and fortunately we were able to do this during the COVID time, which was fabulous to keep the kids out of the ER. So again, we're expecting the dosing was at 150, and again, the dosing should be approved by the FDA for kids less than 12. The subcutaneous study, as I mentioned before, is again, it's been an improvement since the IV medication, but again, it's still every 3 to 4 days. Again, many of these studies were published in the New England Journal of Medicine, showing the high impact on, and also I think the fact that it was just a dramatic improvement in improvement of treatments. Again, a lot of these HA studies are crossover studies. Patients are their own controls. Again, this study was where this medication was approved by the FDA, and it's been approved and it's safe in pregnancy. A newer medication that's been recently approved is an oral medication. Again, patients, although they didn't like danazol or the other oral medications, they don't necessarily like IV medications or sub-Q medications. Recently, an oral study has been studied in a phase 2 to determine, and this was a European study. This led to looking at a plasma kallikrein. It's an oral plasma kallikrein inhibitor. And again, in the initial studies, they'd looked at dosing to look at kinetics to see how quickly the percent inhibition of plasma kallikrein could occur in the dosing. This led to the phase 3 studies that we did here at Sinai that we were part of, looking at different doses, and patients, again, the attack endpoint is looking at the attack rates. And these studies were completed. And what they found was that a lot of these studies, we have patient diaries that report their attack rate. And again, at both the doses of 150 or 100, 110 a day, it significantly met endpoints. And in this December of 2020, the FDA approved this medication as an oral medication. So again, we're really opening up the landscape for patients. They have a sub-Q medication they could potentially take once a month, or an oral medication that they could take daily. Another recent study that we completed is a monoclonal antibody to phase 2. There's also some other pipeline therapies that are early stages, looking at gene therapies. And also at Sinai, we're going to be looking at some acute therapies that are oral medications, some oral plasma kallikrein or small molecule bradykinin 2 receptor antagonists. So it's very exciting that what's in the pipeline. So just to touch upon this study, because we did it here at Sinai and we recently completed, is that factor 12A is a major trigger for initiation of bradykinin production. So it's elevated in patients with HAE. CSL Behring developed a recombinant monoclonal antibody against activated factor 12, which is given once a month. This is a phase 2 study where patients have to qualify based upon a certain number of attacks, and we studied different doses with the primary endpoint in a decrease in attack rates. This slide doesn't come out all that well, but the main point is that looking at placebo, compared to the different attack rates, the attack rates are significantly decreased at the different doses of the anti-factor 12 molecule, and the use of rescue medications is also significantly decreased. So again, this is going into phase 3 studies, and this will also potentially offer a nice option for patients to treat monthly rather than an IV medication every 3 to 4 days. Focusing on some of the triggers of HAE, as I mentioned before, ACE inhibitors are a major trigger. I recommend, I actually put down in patients' charts that they have allergies to ACE inhibitors, so they aren't given it. Estrogen is a major trigger. This is a study that a small study that my lab technician, Jeanette Birmingham, and I did in our lab, looking at the potential mechanisms of estrogen and bradykinin. As one of the previous slides showed before, we don't quite understand the mechanisms, but we feel that estrogen interferes with the degradation of bradykinin. Because we couldn't ethically give patients with HAE estrogen, we recruited patients getting oral birth control pills with estrogen and drew levels of activated factor 12 and cleaved high molecular kininogen at the start of taking estrogen-containing birth control pills and 3 months later. Again, this is a small study, and we presented this as a poster. But what you can see is that after 3 months of taking estrogen-containing birth control pills, factor 12A, for the most part, and cleaved high molecular weight kininogen tends to increase, which tends to show us there's a potential mechanism of why estrogen is exacerbating HAE. Other triggers include surgery, trauma, invasive dental work. So we have to do counseling for patients. Again, I explained to patients, you have about a 24-hour window. So if it's emergency surgery, get the surgery first, and then we'll treat with C1 inhibitor. But again, this is where there's a lot of work that has to be done in coordination between if it's a planned surgery or procedure. Then we have to coordinate with pre-treatment. Our gold standard would be C1 inhibitor 1 to 2 hours prior. Again, with some of the newer medications, we don't have guidelines. They weren't studied this way. But again, so we're recommending C1 inhibitor 1 to 2 hours beforehand. We do have C1 inhibitor on formulary at Sinai, which is great. So if a patient is admitted, we have Bernard here. If C1 inhibitor is not available, you can use, this is very, I would say, what we did in the past, FFP or increased androgen 7 to 10 days beforehand. We rarely do that anymore. The treatment of HAE with normal C1 inhibitor, there are very few trials. There are some ongoing trials with the plasma kallikrein inhibitor, the sub-Q, and the anti-factor 12. But again, these are hard studies to do because it's hard to make the diagnosis. We would say to avoid estrogens, progesterones may help. Tranexamic acid may help as well. C1 inhibitor and icatibant, which is the bradykinin 2 receptor antagonist. So in summary, I really think it's critical to important to determine if angioedema is histamine mediated versus bradykinin mediated. I've seen several patients come into my office who unfortunately have been treated different ways. I've had patients treated as if they have HAE and they don't have HAE. And again, this is medication that is being inappropriately used, that's expensive. And a couple of years ago, there was actually a shortage of C1 inhibitor. And what happened is that the patients with HAE were unable to get their C1 inhibitor, and I had patients ending up in the emergency room with airway swelling. So again, you really have to, it has to be careful with making the diagnosis. And it's also, patients, you have to determine if they have histamine mediated. Because they don't respond to a lower dose of antihistamine doesn't mean it's not histamine mediated. So we don't want to jump the gun and start treating as if it's HAE or bradykinin mediated. HAE is a rare disease, so it's important to confirm the diagnosis prior to treatment. The diagnosis is a C4 level, usually repeat it twice. And I repeat the C1 inhibitor function twice as well. And you have to handle that very properly. If it's left on the tabletop, again, it can degrade and you can get a inaccurate diagnosis. And the treatment goal really has changed over the past 10 years. It's amazing to see how the quality of life of patients has improved immensely. Patients are traveling. They feel that they can board an airplane. And the goal is to allow patients to live as normal of life as possible. And it's actually incredibly amazing. And I feel very fortunate to be part of treating patients with HAE in the past over a decade, just to see this transformation. And as I mentioned before, newer treatments are improving the quality of patients' lives. So I would like to thank you, but I'd also like to acknowledge, importantly, Jeanette, who has helped me with several of the laboratory studies, the clinical trials office, who has helped me conduct the studies, the research pharmacy with Ivy Cohen, and the Hereditary Angioedema Association, which is an incredible association, and the patients who have participated in the study. It's not easy. Patients, have to endure going off of medications, potentially having attacks, coming in. It's a lot of work, but they really feel like it's worth it, and it's made in a huge advantage. And so I'd like to thank you, and I'm going to leave you with sort of a slide here just to put up. We're doing, I know this is not related, but again, we're doing a study with the NIH looking at allergies to COVID vaccines. So if you have any patients, please contact us who haven't received the vaccine or are concerned about receiving it and have allergies. So I'll leave that up there. So thank you. And I would like to take any questions. Oh, how do I do this?
Hi, yeah, so we have a couple questions in the chat.
Okay. Okay.
First question, does treatment with a factor 10A inhibitor affect the coagulation system?
Factor 12 or factor?
Oh, sorry, factor 12A.
Okay, so many of these studies, that's a good question. It actually will prolong the PTT, but clinically it doesn't lead to, it is not clinically significant. I have had patients, who've been on some of these studies. I had one patient who had a planned surgery, and she was on the lanadelumab study and that her PTT was prolonged, but again, it's a more of a lab phenomenon than clinical outcome.
And then the next question, what is the mechanism of the urticaria that has occasionally been seen in patients with Hashimoto's thyroiditis?
Okay, so we don't exactly know the mechanisms, but what we think it occurs is that this would be an example of histamine-mediated angioedema, which can present with swelling and hives. And many times patients, they will develop, if they have one, I try to explain to patients, if they have one autoimmune type condition, it means that their immune system is not completely in check, and they may be making antibodies against the mast cell. And there's a couple of antibodies. There could be antibodies against the high affinity IgE receptor, or some of the other antibodies in the mast cell. So what happens is that we use, now we have some markers of these antibodies to the mast cell that we can use as a chronic urticaria index or some of the anti-IgE receptor antibodies. But in the past, we used thyroid antibodies as a surrogate marker. So many times patients who have antibodies to the mast cell also have antibodies to their thyroid. So it's part of my evaluation, but I explain to patients, I will also send the TSH. It doesn't mean that if you have the antibodies to the thyroid and your TSH is normal, that you treat. It's a marker, and it's something that I recommend then that patients follow up every 6 months or so. But again, when patients present with swelling, and hives, again, this is another frustrating disorder for patients because they can't necessarily put their finger on the cause. So that's a little bit of a roundabout way of explaining what the thyroid markers are used for. It's a surrogate marker of antibodies to the mast cell.
And then a comment from Dr. Kohler, great work in presentation. And then his question, have there been any advances in understanding how psychological stress initiates attacks? He recalls a patient who was a professional bowler who developed hand swelling the day before tournaments.
Yeah, we're working on that right now. And again, it's measuring stress. We all know it for patients. I mean, patients will tell you during stress, my flare is going to attack. But again, we don't exactly understand the mechanisms at this point. And we have with the HAEA, we have a large database, and we're collecting genetic data, patient diaries. So hopefully we can understand some of this a little bit better. But again, it's hard to measure, even though we know it when patients tell us, but the mechanisms, it's a little bit, don't quite understand at this point.
And then the next question in the chat, have you started prescribing the oral C1 inhibitor now that it's FDA approved? And how does its efficacy compare to IV and subcutaneous formulations?
Okay, so actually maybe I misspoke, but it's an oral plasma kallikrein inhibitor, not the oral C1 inhibitor. So we did some of the studies with the oral C1 inhibitor, oral plasma kallikrein inhibitor. Unfortunately, it works, but I'm not, how do I say this? It's an advancement, but it doesn't, if I compare it, there's no head-on-head studies compared to some of the sub-Q plasma kallikrein inhibitors. The oral plasma kallikrein inhibitors don't tend to prevent attacks as well as the sub-Q formulations. And one of the side effects is actually GI upset. So in the initial studies that we did, a lot of patients had GI upset, and we didn't know if it was from the medication or his HAE attack. So I think it's a good option for patients, especially if they're a little phobic of needles and giving it to themselves. But again, a lot of the patients feel good taking medications just once a month, and they don't want to go back to taking a daily medication, especially maybe if it doesn't control as well. So I have one patient on it, continuing from study. But again, it's a patient-led decision, but it hasn't been as probably huge as uptake as we probably would have expected.
Thank you. And then our next question, how are expensive medications paid for if the patient is not independently wealthy or on Medicaid?
Yeah, that's a good question. There are several insurance. I spend a lot of time doing prior authorizations. Again, there are several different ways. Probably the best way is there's a patient assistance program called PSI. So if patients don't have income, they don't have insurance, what we do is we contact PSI, and the patients will send in tax returns, and they will get medications for free. I have a couple patients who have this, the PSI support, which it's amazing. So that patients will get medications. The HAEA Association also is very helpful in obtaining medications for patients as well. But again, it is a good question because these medications are incredibly expensive, and insurance has a lot of pushback on prescribing medications, even with patients who have been on it for years and have HAE. So it's a lot of time spent on this approval.
And then our last question, have HAE patients suffered greater rates that you know of severe COVID disease? And what are your thoughts about the proposed relationship between COVID and bradykinin?
Yeah, I mean, so there's definitely, we've been looking at this as well, not necessarily the mechanisms, but we haven't seen increased rates of COVID or increased severity of COVID in patients with HAE, even though there is, a potential link. We haven't seen it.
All right, one last one under the wire. Were there particular barriers that precluded HAE treatment innovation in that 40-year period between 1971 and 2008?
The barriers that I think were, one, it was a rare disease. So that was probably the hugest, if that's a word, component. And then you have that C1 inhibitor was available in Europe. And this was available probably in about the 1980s. And this was the time C1 inhibitor is a blood product. So this was about the time that HIV was discovered to be a bloodborne product. So really the enthusiasm for a blood product in the United States was not high. There was an initial trial that was in the United States I believe it was in the 1990s, looking at the use of C1 inhibitor for HAE, and the trial was poorly designed, so it did not meet its endpoints. And then between those two factors, it really wasn't looked at until several years later. So it was put on hold, and a lot of this push was done through the HAEA, really pushing the FDA to approve some of these more recent studies.
Thank you so much for those answers to the questions, and thank you for a wonderful talk, Dr. Busse.
Oh, you're welcome. Thank you for having me.
Yeah, our very great pleasure. Thanks, everyone.
Okay, thank you.